Welcome. Our mission today is straightforward. A rapid, really comprehensive review of ketamine, specifically for you, the healthcare professional listening. This is an agent with, well, unique power, but also unique risks. We're focused entirely on giving you the maximum clinical utility and safety knowledge from the available data.
Precisely. Ketamine really is a singular agent in our anesthetic toolkit.
It is.
And understanding its, let's say, multifaceted pharmacological profile, that's absolutely key to optimizing patient care and, frankly, avoiding critical errors.
Right.
We need to go beyond just the textbook definition, explore the real-world clinical nuances.
Okay, so let's start right there. How this compound fundamentally works.
Let's lay the groundwork. First question.
Let's structure this, starting with its identity.
Okay, Q1. How is ketamine classified pharmacologically? What group does it belong to?
The technical classification is very specific. It's a dissociative anesthetic. And that classification, dissociative, it immediately signals the kind of clinical state it induces. It's a functional, sensory, and psychological detachment from the immediate environment.
That idea of dissociation, that's really what sets ketamine apart from pretty much every other agent we use.
Absolutely.
But just knowing the classification isn't quite enough, is it? We need the mechanism behind it.
Agreed. Q2. So what's the primary mechanism of action? What drives this profound state of dissociation and analgesia?
The mechanism is highly specific. Ketamine is an Nmethyl deaspartate receptor antagonist.
The NMDA receptor.
Yes. Essentially, it blocks the flow of ions through those NMDA receptor channels in the central nervous system.
And we really have to stress that this receptor antagonism, it's the absolute cornerstone of its activity within the brain and spinal cord.
It is.
But we can't just stop at the primary action, can we? Because ketamine is actually more complex than just a simple antagonist.
That's a really important point. For you, the practitioner, there are two immediate points of complexity to recognize here. First, ketamine is metabolized by the liver into an active metabolite. It's called norketamine.
Active meaning it still does something.
Yes. Norketamine is also an NMDA receptor antagonist. Sometimes it possesses up to, say, 30% of the parent drug's activity.
Yeah.
And this metabolite is longer acting. So that means ketamine's effects on the patient, especially the psychoactive bits and the pain relief, can persist well beyond the initial half-life of the ketamine itself.
That explains why effects can linger. What's the second point of complexity?
The second point involves its physical structure. We often use what's called racemic ketamine. That's a mixture.
Right, mix of isomers. What's the clinical relevance of those different forms, the stereoisomers?
Well, racemic ketamine is a 50-50 mixture of two mirror image molecules, R-ketamine and S-ketamine.
Okay.
Clinically, S-ketamine, which you might know as esketamine, is often preferred. Why? Because it possesses roughly 3 to 4 times the analgesic potency of the R-ketamine form.
3 to 4 times. That's significant.
It is. And this greater potency means S-ketamine requires a lower dose to achieve the same effect. And theoretically, that should translate into fewer associated side effects, particularly those undesirable psychoactive emergence issues.
Okay, so understanding that structure, the metabolism, it really helps predict the patient experience much better.
Definitely. Which brings us to the next logical question. Q3. What specific neurobiological state does this mechanism, this NMDA blockade, actually induce in the patient?
So this action leads directly to that state we call dissociative anesthesia.
Right.
The patient exists in this sort of cataleptic-like state. They might seem conscious, their eyes could even be open, their airway reflexes often preserved, but they are functionally disconnected from external stimuli. That includes pain.
And from a neurobiological view, the dissociation is thought to come from selectively interrupting transmission pathways between the thalamus and the cortex, that thalamocortical pathway. This essentially stops sensory input, especially pain signals, from reaching the higher processing centers in the brain. So they're physically present, but psychologically and sensually, they're absent from the event.
That's a powerful effect. Q4. So what are the two key components of this state dissociative anesthesia that give us tangible benefits during a procedure?
Okay, the first component is profound analgesia, pain relief. Ketamine provides really potent pain relief. It covers both somatic pain, surface pain, and visceral pain from internal organs.
That's a level of analgesia that very few single agents can match without causing significant cardiorespiratory issues, right?
Exactly. You typically need multiple drugs or risk serious depression of vital functions.
And the second component?
The second component is amnesia, that interruption of the thalamocortical circuit we mentioned. It impairs memory formation specifically related to the procedure itself.
Which is huge for patient recovery.
Right.
It reduces the chance of traumatic recall, increases overall comfort after the procedure.
Absolutely essential for patient experience and psychological outcome.
Okay, so we've established the pharmacology, how it works. Now let's shift gears. Let's talk about clinical utility. Where and how do we actually use this agent?
Right, the practical side. Q5, what are the primary established clinical uses for ketamine in medicine today?
Okay, the applications generally fall into, let's say, 3 established categories and maybe a 4th that's rapidly gaining ground.
Go on.
First, general anesthesia. It's used for both the initial induction phase, getting the patient under, and also for maintaining anesthesia during the surgery. Sometimes alone, sometimes as part of a balanced technique with other agents.
Okay, anesthesia induction and maintenance. What's second?
Second is procedural sedation. It's highly valued for short, painful procedures. Think orthopedic reductions, setting a dislocated joint, maybe burn debridement.
Right, things that hurt but don't necessarily need full general anesthesia in an OR.
Exactly. And its profile often means patients are stable enough that these procedures can sometimes be managed safely outside the main operating room environment.
Okay, and the third category?
Third, and this is where I think its benefits really stand out, its use in emergency settings.
Yeah.
In the emergency department or maybe in pre-hospital trauma care, ketamine is often the go-to agent for rapid sequence intubation or for procedural sedation. And that's precisely because of the safety profile we're about to get into.
That hemodynamic stability is a major factor there.
Absolutely. And that 4th category you mentioned, the one gaining prominence.
Right. The 4th category, and this is something all healthcare providers really need to be aware of, is its role in acute and chronic pain management. We're talking subdissociative dosing here.
Subdissociative, meaning lower doses.
Exactly. The analgesic effect, the pain relief, kicks in at doses significantly lower than what you need for that full dissociation we talked about.
How low are we talking?
Doses as low as 0.1 to maybe 0.3 milligrams per kilogram given intravenously can provide powerful pain relief, often sparing the need for large doses of opioids.
Which is useful for
managing conditions like refractory acute pain, complex regional pain syndrome, or even really severe post-operative pain, where opioids aren't enough or cause too many side effects.
And beyond just blocking pain signals, its mechanism suggests maybe a deeper utility. You mentioned NMDA receptors are involved in chronic pain mechanisms.
That's right. The NMDA receptor is implicated in central sensitization and neuroplasticity. These are the processes that underlie many chronic pain states.
So ketamine might actually modify the pain process itself.
There's evidence for that. By modulating this receptor, ketamine has shown efficacy in sort of resetting certain chronic pain states. This makes low-dose infusions an important, though specialized, tool for pain specialists.
Interesting. Any other uses we should touch on?
We should briefly mention 2 specialized, often off-label uses that are really changing practice in certain areas: refractory status epilepticus.
Seizures that won't stop.
Exactly. And treatment-resistant depression. Its rapid onset and unique mechanism make it a fast-acting option in both critical care neurology and psychiatry when standard therapies haven't worked.
And the dosing for depression is different again, isn't it?
Very different. For depression, the doses are often in the microgram per kilogram range, much, much lower than the milligram per kilogram doses used for anesthesia or even acute pain. It's a whole different paradigm.
Okay, let's focus now on the distinct physiological effects of ketamine. This is what really sets it apart from our more traditional agents like propofol or midazolam, which primarily act on GABA receptors.
Right. The unique profile, Q6. Let's start with a key efficiency point. What's the dual benefit of administration that makes it so useful in acute settings?
That benefit is really the synergy you get. You achieve simultaneous effective pain relief, the analgesia, and you induce sedation at the same time.
2 birds, 1 stone.
Exactly. Clinicians are hitting 2 major therapeutic goals with just one agent. That really streamlines management, especially when things are moving fast.
Okay, next point. This is crucial for critical care and emergency medicine. Q7. Why is ketamine consistently seen as advantageous in airway management compared to agents that cause significant respiratory depression?
The primary advantage, and it's a big one, is that ketamine typically preserves protective airway reflexes. We're talking about the cough and gag reflexes.
That preservation. where does it come from? Why doesn't it depress breathing like other sedatives?
It stems from the fact that ketamine provides functional anesthesia, not necessarily profound central respiratory depression like opioids or high-dose propofol do.
Mm-hmm.
So even while the patient is dissociated, the brainstem and the medullary respiratory drive centers, they remain largely active.
Which means spontaneous ventilation is often maintained.
It's often the rule, not the exception. This provides a massive safety margin, especially when securing an airway might be difficult or delayed.
But it's not completely without risk to the airway, is it?
No, absolutely not. It's important to be clear here. While it's rare, airway complications can still happen. Laryngospasm, for instance, is a known potential complication.
When would that be more likely?
It seems more likely if the dose is pushed very rapidly intravenously, or if there's manipulation of the pharynx or airway before the patient is fully dissociated.
And management for laryngospasm?
It's the standard management, often requires positive pressure ventilation, maybe suctioning, and if it's severe, you might need a neuromuscular blocking agent, like 6-phenylcholine. But the baseline risk with ketamine is still significantly lower than with many other induction agents.
Okay, good clarification. Now let's move to the cardiovascular system. This is probably the most unique aspect of ketamine's physiological profile.
Agreed. Q8. How does ketamine specifically affect the cardiovascular system and hemodynamics? What do we see?
Ketamine generally supports hemodynamic stability. The immediate observable effects are sympathomimetic. They mimic the sympathetic nervous system, meaning it increases the heart rate, the HR, it increases blood pressure, the BP, and critically, it increases cardiac output, the CO.
Which is why it's often called the cardiac-friendly anesthetic,
Yes.
right? Especially compared to something like propofol, which typically drops blood pressure.
Exactly. It achieves this stability primarily by centrally stimulating the sympathetic nervous system.
How does it do that?
It leads to a release of endogenous catecholamines. Essentially, the body releases its own adrenaline and noradrenaline.
Oh, okay.
And this sympathetic drive usually offsets any potential hypotension that you see with almost all other induction agents.
But there's a really important nuance here, isn't there? This is something that really separates expert understanding from just basic knowledge. Ketamine isn't purely stimulatory.
That is absolutely correct, and this is critical. Paradoxically, ketamine is also a direct myocardial depressant.
Meaning it can weaken heart muscle contraction.
Yes, if you test it on isolated heart tissue in a lab, ketamine actually reduces contractility.
So why do we see the increase in heart rate and blood pressure in most patients?
Because in a typical patient, someone who has adequate stores of those endogenous catecholamines we mentioned, the massive central sympathetic stimulation overcomes that direct depressant effect. The net result is the increase in HR, BP, and CO we usually see.
Okay, so that leads to a crucial question. What happens if you give ketamine to a patient who doesn't have those adequate catecholamine stores?
Yeah.
Someone who is critically ill, maybe catecholamine depleted.
Right. Think about a patient in severe septic shock or someone with chronic end-stage heart failure, or maybe a patient who's already maximized on high doses of vasopressor infusions.
Their sympathetic system is already exhausted.
Exactly. In that fragile state, the body's ability to release more endogenous catecholamines is tapped out. The central sympathetic stimulation provided by ketamine, it just doesn't provide the necessary cardiovascular support. And then the direct myocardial depressant effect is unmasked. So instead of getting the hemodynamic support you were hoping for, the patient might experience profound hypotension and even cardiovascular collapse.
Wow. So patient selection based on their underlying illness and physiological state is absolutely essential here.
Critical. It means ketamine isn't some magic bullet for all unstable patients. It's often a fantastic choice for the unstable patient who still has adequate sympathetic reserve, but potentially dangerous in someone who's already depleted.
That distinction is incredibly important for safe practice.
Okay, the benefits are certainly compelling, particularly that hemodynamic profile and airway preservation. But safety demands rigorous vigilance, especially regarding the psychoactive effects.
Right. Let's tackle those. Q9. While ketamine is generally well tolerated, what are the main potential adverse effects that healthcare professionals like you need to monitor for, especially during recovery? And how can we manage them?
The primary adverse effects really center on what we call emergence phenomena, as the patient is waking up.
Okay, like what?
Patients may experience vivid, sometimes intense dreams or even hallucinations during that recovery period. These can be quite unsettling or frightening for the patient.
And that's a consequence of date.
It's a consequence of the ongoing psychoactive effects, often mediated by that active norketamine metabolite we discussed earlier, which hangs around longer.
Okay, vivid dreams, hallucinations. What else?
The second major effect is delirium. Patients might show confusion, disorientation, agitation, or restlessness. This can range from just mild confusion to, in some cases, severe combativeness.
Are there patients more at risk for these emergence phenomena?
Yes, clinicians need to identify the risk factors. Higher doses of ketamine definitely increase the risk. Rapid intravenous administration also seems to contribute.
Patient factors.
And the patient's underlying psychological state matters too. Especially a history of psychosis or significant pre-existing anxiety, these can predispose someone to a more difficult emergence.
So how do we manage this or prevent it?
Management is really twofold. First, there's proactive management. This involves creating a quiet, low-stimulation recovery environment, sometimes called darkroom recovery.
The idea being to minimize sensory input.
Exactly. Minimize sensory input that might feed into that dissociative state or trigger agitation as they emerge.
And the second management strategy.
The second strategy is pharmacological. Co-administration of a benzodiazepine, something like midazolam, is known to be highly effective.
How does that help?
Benzodiazepines seem to reduce both the incidence and the severity of these emergence phenomena. And importantly, they usually do this without significantly impairing the desired analgesic or anesthetic effect of the ketamine itself.
So it's common practice to give a benzo with ketamine.
Yes, a standard prophylactic approach often includes giving a small dose of a benzodiazepine, maybe shortly after the ketamine bolus, specifically to smooth out the recovery phase.
Good to know. Okay, let's move on to the precise mathematics of administration, the dosing.
Right. Numbers are key here. Q10. Regarding dosing, what are the specific guidelines for intravenous or OBS administration when you're using it for the induction of general anesthesia?
Okay, for induction via the intravenous route, the standard dose range is 1.0 milligram up to 2.0 milligrams per kilogram of actual body weight.
1 to 2 milligrams per kilogram, IV. Any tips on giving that dose?
Yes, this is critical. That dose should be administered slowly, typically over a period of 60 seconds or even a bit longer.
Why slowly?
Pushing it too fast increases the risk of adverse cardiorespiratory effects, like apnea or that laryngospasm we mentioned. And importantly, slower administration seems to reduce the incidence and severity of those emergence phenomena during recovery.
Makes sense. How fast does it work for?
Onset is extremely rapid via the IV route, usually well within 30 seconds.
And just to reiterate, what about the IV dose for pain, the subdissociative dose?
Right, for acute pain relief, that standard subdissociative bolus is much lower, typically ranging from 0.1 milligrams to 0.3 milligrams per kilogram.
0.1 to 0.3 milligrams, and that usually keeps the patient conscious.
Yes, that dose usually maintains full consciousness while providing pretty profound pain relief.
Okay, let's switch routes. Q11. Given the differences in bioavailability and time to peak effect, what's the standard dose when you have to use the intramuscular or IM route? Say, for procedural sedation when you can't get an IV.
The standard intramuscular dose is significantly higher than the IV dose. Generally, you're looking at 4.0 milligrams up to 6.0 milligrams per kilogram.
4 to 6 milligrams per kilogram IM, why so much higher?
That higher dose basically compensates for the slower and less complete absorption from the muscle compared to directly into the vein.
And onset time for IM?
Onset is slower, as you'd expect, typically around 3 to 5 minutes, but the IM route offers really essential versatility, doesn't it?
Absolutely. For managing a highly agitated patient where getting an IV is impossible, or maybe in pediatric patients where access can be tough, or out in the field in trauma situations.
Is there an upper limit for IM dosing?
Well, the maximal IM dose might sometimes reach up to 10 milligrams per kilogram if really extreme sedation is required, perhaps in cases of severe agitated delirium. But you have to weigh the increased risk of prolonged emergence and potential respiratory depression at those very high doses.
Definitely a risk-benefit calculation there. Okay, one more dosing scenario, Q12. What if you're using a continuous infusion, say, for maintaining an anesthetic state during a longer procedure? What's the required dose range then?
Right. For a continuous infusion to maintain anesthesia or deep sedation, the required dose range is typically 1.5 milligrams to 1.0 milligram per kilogram per hour.
0.5 to 1 milligram per kilogram per hour.
Yes. And this allows you to sustain that anesthetic or analgesic state for longer procedures. But that infusion requires really meticulous titration. You can't just set it and forget it.
Titrating against what?
Against clinical endpoints. Not just watching the vital signs, but often using structured assessment tools. Things like the Richmond Agitation Sedation Scale, the RASS score, to make sure the patient is consistently at the desired depth of sedation.
And just briefly, what about continuous infusions for chronic pain? Are those doses similar?
No, it's worth noting that for those specialized continuous infusions, like the ones used sometimes in chronic pain management, the required doses are dramatically lower. Sometimes they're titrated in micrograms per kilogram per minute, not hour. It reflects a completely different goal neuromodulation rather than anesthesia.
Okay, so let's try and synthesize this extensive clinical review. Ketamine. It's clearly far more than just another sedative agent. Its unique mechanism, that NMDA receptor antagonism leading to functional dissociation. It provides profound analgesia while, crucially, maintaining that margin of safety by preserving airway reflexes and often supporting cardiovascular function.
Absolutely. But we have to reinforce the need for vigilance. Knowing about its complex metabolism, that active norketamine metabolite, and its tendency to cause emergence phenomena, it means you absolutely must prioritize careful monitoring and structured support.
Which includes
things like creating that calm recovery environment and considering the proactive use of benzodiazepines, not just during the procedure, but critically after the acute management phase during recovery.
And by really internalizing all this nuanced data, knowing the difference between IV and IM doses, understanding the role of norketamine, and grasping that critical distinction between its direct and indirect cardiovascular effects.
Yes.
You, the listener, can really transform your approach, especially when managing high-risk patients. It allows for much more informed decision-making.
Well said. And that brings us perfectly to the final thought we want to leave with you today.
Okay.
We've discussed the profound impact of the NMDA blockade. But considering ketamine's growing role in areas like refractory depression and chronic pain, how might a deeper understanding of its interaction with other neuroreceptor systems beyond just NMDA potentially unlock future pharmacological strategies?
So looking beyond its primary mechanism.
Exactly. Understanding the precise mechanism doesn't just dictate today's dose. Perhaps it illuminates tomorrow's treatments. Something to think about.